My name is Todd Mitchell. For those of you who don't know me, I'm the Chief of Psychiatry at UC Berkeley. Brought my ringers. And I'm going to spend a little bit of time talking about the psychodynamics of difference, dealing with clients where there's difference in the room between the therapist and the client, and some things that might be helpful to you. And I'm lucky enough to have Dr. Thomas Parham join me to add a little extra expertise to the talk. Dr. Parham has really spent his career looking at issues of this sort and how to intervene clinically in an effective way when there's difference in the room. So I really appreciate you joining me here. Thank you. I'm not really all that into lecturing so much, so I'd like to think of this as a discussion, really. So if anybody has any thoughts or any additions or any questions, just chime up, put your hand up, I guess, would probably be the best way to do it, and we'll go from there. Does that make sense? Okay, good. Okay, so learning objectives for our talk today. We're going to become familiar with the concepts of racial identity and some theories that are related to it. We're going to recognize ways that issues of race can manifest as psychodynamic phenomena in the consulting room, and then we'll be able to apply racial identity and racial interactive models in some clinical case formulations. I will present at least one case from my work, and if this sparks any thoughts on anybody's part about any particular cases you have, we could also hear about your cases and kind of discuss them in this context, if you feel comfortable with that. So, an overview, I'll give you an introduction, then we'll talk about racial identity development theory, Janet Helm's theory, racial interaction model theory, which is born from this theory, and looks at dyadic interactions within the context of racial identity development. We'll talk about transference and countertransference issues, and then I'll present some clinical case material. I always think in these kinds of talks, the clinical material is really the most interesting stuff, so I'm going to try to get to that and try not to get hung up too much in theory, but please let me know if you want to spend a little bit more time on any of that. Okay, so we'll start with a few words from David Satcher. Mental illness, no less than mental health, is influenced by age, gender, race, and culture, as well as additional facets of diversity that can be found within all of these population groups. For example, physical disability or a person's sexual orientation. This is the key point, though. To be effective, which is our goal, the diagnosis and treatment of mental illness must be tailored to all characteristics that shape a person's image and identity. And the emphasis here is mine, not Dr. Satcher's. The consequences of not understanding these influences can be profoundly deleterious. Our job is to do no harm, so we really need to take some of this stuff seriously. So where and when, or when and where, is the influence of race felt? Differences in access to care, that's what Dr. Satcher was talking about. Differences in the quality of health care. Differences in pathophysiology. There are differences in differential diagnosis and treatment planning, differences in pharmacodynamics based on genetic differences, and then therapeutic engagement and rapport, which is where we're going to focus. So the basics about racial identity development. And are people familiar with Janet Helm's or any of her work? Everyone's pretty familiar with it? Good. Now, I won't belabor it too much. So the idea is that your racial identity is a part of your identity. And if your identity is not well consolidated, you're going to have trouble coping with things. Self-reference group and intergroup relational schemata involving race are important facets of one's overall sense of identity. And as identity consolidation proceeds, various constellations of schematized attitudinal and experiential reactions can be evoked depending on situational, contextual, and individual factors. One of the most important things I think about Dr. Helm's theory is that it's what I would call quasi-epigenetic, which means it is a progression of developmental phases, but importantly, something she emphasized was that people, depending on the context you find yourself in or the situation you find yourself in, you can regress wholly or progress. You can partially regress. You can actually stand in two different phases or statuses, as she calls them. You can stand in two different statuses at the same time. So it just gives you a sense of how complex the nature of this is. Development of mature, flexible, adaptive repertoire of mechanisms for coping with race-related stimuli require one to contend with a socio-developmental task. And because role relationships in North America are informed by one's race, that task is going to be different depending on what your identified race is. It's also going to be different depending on what race you are identified to belong to by other people. So it's not just you defining yourself, although that's a very important part of identity. It's also how you're defined by other people that impacts, and there can be conflict and dissonance there sometimes, which is part of what Thomas was talking about in the last hour. So again, this is epigenetic progression. People can get hung up in certain phases or move between phases, forward and backward. Okay, so there are some generalizable facets. The first phase, regardless of your racial identity or your racial categorization, let's say, the first phase is colorblindness. Second phase is confusion and internal conflict. Third phase is recognition of the importance of race and internalizing one's own racial culture. The fourth is integrating all of that. And then the fifth is solidifying what has been integrated. So for Black Americans, and this should be reviewed because it looks like everybody's familiar with this, pre-encounter, encounter, immersion phase, and internalization for Black Americans and people of color. And then there's some research that says that these are some of the general psychological functioning correlates that we're seeing in people in different developmental phases. I'll get to really what the upshot of that is in a second. For white Americans, contact, disintegration, reintegration, pseudo-independence, and the rest. Autonomy being the solidification phase. And again, with the general psychological functioning. So here you can see it's sort of color-coded to make it a little bit easier to see. In the blue phase, that's the most primitive phase. There's a denial of significance of race and acceptance of stereotypes. Then people can progress into a conflicted awareness of the significance of race. And then lastly, as these things are internalized, integrated, and solidified, you get an authentic exploration of race that leads to a fuller consolidation of identity. A little bit more research. You can see over here we're talking about self-actualization, and this is for people identifying as white in race. And what you see is that in the less well-developed phases, there's less self-actualization, and in the higher ones, there's more. Merely saying it's good to be better developed. So how does this theory apply to therapeutic dyads? This is called the racial interaction model, where there are basically 4 types of dyads. There's a progressive dyad. And if you think about this in the terms of sitting down with a patient and doing therapy, you know, if your level of sophistication, whether it's about race or about you know, cognitive behavioral strategies or about any number of different things, if you as the therapist have something to offer the patient that they do not have yet or they haven't developed well enough yet, then you're really in a progressive dyad. Parallel dyad is where the therapist and the patient are about at the same level, and then the subtypes of parallel high, which is where the therapist is a little bit, maybe in some areas, a little bit more progressed than the patient, and parallel low would be the opposite of that. A crossed dyad is where the therapist and the patient's attitudes are in direct conflict with one another. And then a regressive dyad, and you can imagine that this does not bode well, is where the patient is actually at a more sophisticated identity level than the therapist. The therapist is poorly equipped to do much to help the patient in that realm.
By the way, there's a parallel on that last slide. there's a parallel, by the way, for supervision dyads, because you have a generation of students coming out now who are actually sometimes more culturally competent than the supervisors who supervise their clinical work. Anybody been through that? Yeah? Who will admit it, right? Okay.
It's an excellent point. There's a short movie called Black Psychoanalysts Speak. It's a documentary about a handful of black psychoanalysts in New York City. And this is basically what they spend a lot of the documentary talking about, is how as black psychoanalysts, I mean, to be a psychoanalyst, you have to go through an awful lot of supervision. And in supervision, they would find themselves sitting with their supervisor saying, hey, you know, this happened and it's charged racially and I'm wondering how to think about it and what do you think about it? And just not getting enough back from them on how to think about this in a sophisticated psychodynamic way. So again, more research. This time we're talking about working alliance ratings, and we're looking at therapists. And these are white therapists, and we're seeing that as, and I think Thomas has some work that directly speaks to some of this, that when you're talking about the less well-developed phases, you're having lower working alliance coefficients than when people are moving into these higher areas. So the upshot of this is the better developed your own racial identity and the more consolidated your whole identity is, the better a therapist you're going to make. A little bit more research on this is that in this study, trainees' disintegration and reintegration attitudes correlated negatively with working alliance ratings. That's what the graph showed. The higher sophistication levels correlated with with better ratings, and the client's race did not affect the working alliance ratings at all, according to that study. So again, this is about us. It's about therapists. Okay, how might countertransference and transference phenomena manifest in the context of race? People are familiar with Lillian Comas-Diaz? Great, okay. So I'll keep this short. So we've got the intra-ethnic transferences, patient to therapist, omniscient and omnipotent therapist, the traitor, the self-racist, and an ambivalent transference. And then on the other side, the inter-ethnic, where there's difference in the room, that's more obvious. You've got over-compliance and friendliness, denial, mistrust, and again, ambivalence. On our side, on the countertransference side, over-identification can happen when you have an intra-ethnic dyad. Distancing, cultural myopia, ambivalence, anger, and then survivor guilt. And then on the countertransferences, you can see them here, clinical anthropologist syndrome. People familiar with that one? It's basically where the therapist gets so curious and interested in the patient's cultural presence that they get distracted from the rest of the clinical work. Tell me more about, Jewish culture, kind of thing. Not so much because you want to understand who this patient is and where they're coming from, but because you're fascinated. I attribute this in some ways to asking the patient when they come into your office, what's the traffic like out there? Like, am I going to have trouble getting home? That's for me. That's not for the patient. Right. Okay. So guilt, pity, ambivalence, and aggression can happen also. Okay, so how do we use this framework in clinical practice to inform our psychosocial interventions? These are the clinical cases. Ooh, that's ugly. Okay, pardon me 1 second. Sorry about this. All right, that should be fine. Okay, so RQ, and that's a pseudonym, is a 26-year-old African-American female professional student. She's the oldest of 3 siblings. That should come back. Great. Okay. She's the oldest of 3 siblings, the oldest girl. She's got a younger sister and a younger brother, born to a mother with depression and a father who was emotionally distant. When this patient left their culturally diverse, though segregated suburb to attend a prominent Ivy League college, her family relocated to a predominantly white Midwestern community for her dad's job. They got relocated. Shortly thereafter, her parents separated following an affair between her father and a white woman with whom he subsequently married. This is someone that her father met at work. Both the mother and the patient after that became depressed and sought treatment. The patient presented to me 6 years and several aborted trials of psychotherapy later. She'd also been tried on several medications, none of which worked, or none of which brought her any relief, I should say. And she specifically requested an African-American therapist for her complaint of anxiety, stressed out feelings, which she related to her being the constant object of racially motivated mistreatment by her peers and by faculty in her professional school. My attempts to understand her experience of feeling victimized in this way were met with responses like, come on, you know, the regular racist stuff, you know what they do to us. It's basically what she would say to me. And she seemed reluctant to acknowledge the possibility that there might be differences in our respective perspectives and experiences. So it's important to mention from this case that I got the referral a few weeks before I saw the patient. And the doc who referred the patient to me gave me a little bit of background about why she was referring to me and what the patient was looking for and that sort of thing. And that got my gears turning. And I started thinking, this woman's looking for a black therapist. She feels like she's being discriminated against. Do I understand what she's experiencing? Yes. Is it going to be easy for me to over-identify with her? Yes. So as these 2 weeks were passing and I was kind of chewing on the clinical information that I had, unwittingly, I was building up a set of defenses against over-identifying with her, which I wasn't aware of at the time, unfortunately. So the patient came to me, if I was to categorize her racial identity development, I would say she was in an early phase of immersion, but she had some latent pre-encounter traits. She had some stereotypes that she was carrying. Okay. I think that they were not completely within her realm of awareness, but they were there. For me, I was in internalization phase, but again, I think that there was some questions that were coming up that in retrospect I can look at my reaction to what I had heard she was looking for suggested that there was some issue there. And the interaction model, I would say, based on this, was still progressive, but there were some latent crossed traits. Basically, my immersion attitudes and her latent pre-encounter attitudes could come into conflict with each other. The initial transference that she had, I think fairly obviously from what she was telling me in the first session, was one of omniscience. I would know, I'm black, so I understand. All right. After she heard my responses to her, I think her transference changed fairly quickly to one of ambivalence about me. If he doesn't know what I'm talking about, who is this guy? And maybe even devolving to the point of traitorism, which would be in line with a paternal projection from her father. The countertransferences that I had were ambivalence about seeing the case in the first place, wondering how I should approach her, and then, unfortunately, distancing myself by being excessively neutral with her. When she would say to me, you know, the regular racist stuff, I would say, I don't know. I don't know. Tell me what? Tell me what? You know, what are you experiencing? And the outcome was that she came to see me twice, made a third appointment, didn't show up for it. So premature termination, which is not a good outcome. So what might I be able to do differently in retrospect to engage or connect, as Thomas was saying last hour, to connect with this patient a little bit better? I think if I was able to contain my fear of over-identifying with her and resist acting out on that by distancing myself emotionally from her, I may have been able to draw her in a little bit better. I could have approached her with a more empathic understanding without denying the truth of the matter, which is that I don't know what her experiences are. I don't know what her experiences are. I know what mine are. And I don't know even how they're congruent with each other. So I think if I had come to her more with something along these lines, I'm sure we've had some similar experiences as victims of prejudice, but still it would be unfair for me to, it would be unfair for us, for me to assume that our experiences are identical. So I'd ask your help in helping me understand how your experiences have affected you. there's less distancing in this than I think what I actually projected to her in the moment. Thoughts, questions, comments of any sort?
So, interesting space, and want to thank Dr. Mitchell first of all for that just degree of disclosure. Not many of us are willing to really present a case where we didn't have a very good therapeutic outcome by our own admission, but to present it as a learning moment, I think is pretty phenomenal. So thank you for that. A couple pieces I think that I would say that'll kind of take us back. First of all, when we think about the notion of kind of racial identity and how racial dynamics interact, I want you, if you can project on the screen, a virtual circle on the left, circle on the right, and circle on the bottom. So when we talk, first of all, about how racial dynamics manifest themselves within the counseling situation, we talk about the notion of identity consolidation. And what we're talking about in that case is what we call a PI factor. So part of what you have to be able to do is talk about what is the personal identity of that particular patient. In the second circle is what we call the RGO factor. That is the reference group orientation, meaning what group does this patient or client belong to. So if my PI factor is I'm African American, the group I belong to is African American folk, then that's my PI and RGO. The difference is on the E factor, which is on the bottom, which is the environmental identity. So when we talk about identity congruence, if I believe I'm African American, if somehow I belong to a group who's African American folk, and society treats me like I'm African American, all three of those circles will align and intersect. Now, it doesn't mean that insulates me from the craziness that happens in life. It means that I will have a perfectly formed, nobody's perfect, but as you can get, sense of identity congruence because there's high overlap there. What the case doesn't show, and it's only through extensive treatment and analysis that you could really identify this, is how, given the developmental history of the client in this case, how that informed both her PI factor and RGO factor. So let's assume she totally identified with the African American folk, but also what kind of environmental circumstances led her to the space where she was at. And what then assumptions did that then help her project onto you, because it looked like what she looked at simply was skin color. And what clients sometimes do not understand is the difference between skin color and consciousness. Because they make an assumption that just because he's black, just because she's a woman, just because he or she is gay or lesbian, that somehow they're going to automatically identify with and go with what it is we see. So that's a piece I think that's important within the context of this clarification. Second piece I saw real quickly is when we talk about racial identity theory, it's important to remember contextually where those theories come from, particularly when you're talking about how race dynamics manifest themselves within the therapeutic situation. In the context of normal development, assume you could have a kind of line here that would be the self, that is surrounded by a veil of culture that intersects with the environment. In normal development, assuming that environment is wholesome and healthy, then it would elevate them to a line here, and they would move across where they have a very positive sense of themselves. That's what normal development ought to look like for anybody who lives in a very humanistic, affirming environment that you grew up in with your parents and society and community, whatever. What identity development theory does, so Janet's work, my work, Robert Carter's work, who you're quoting, other folk, is it reminds us of a fundamental contextual point that Bill Cross makes that people forget. That identity development in these racial identity theories is always done within the context of social oppression. Do not consider social oppression to be normal developmental growth. It is not. It is not natural to be oppressed. So if you think about the self, the culture, environmental interaction, If you come from an oppressed environment, then that is likely to move you into this space. So when we talk about the theories of pre-encounter, encounter, emergent internalization, those are the things that can ultimately get you back up to this space as you move through the digressing stages. But there's nothing normal about being oppressed, and that is not normal development within the context of that. So oftentimes, the reaction that clients will have moving through the identity development process vary considerably based upon the environmental context in which they've come through, as well as the experiences that you bring yourself into, being a therapist. So love that part. And then lastly, I'll say that as we talk about a fear of over-identification with the patient, it's an interesting space. But as I mentioned in the last presentation, when we talk about that piece of African wisdom that says that life at its best is the creative synthesis of opposites and fruitful harmony, one of the things I think we want to invite clinicians to assume is not that over-identification is a problem, so now I try to resist it. But in fact, what are the strengths of over-identification that might have allowed me to progress in a way that might have done some therapeutic good as opposed to therapeutic harm?
Right.
Because most supervisors would only see that as therapeutic harm. So I'm not just looking at the bad part about over-identification, but what's the good that you could achieve in that? So if we were thinking about exploring that, why would her over-identifying with Dr. Mitchell be a good thing? One. So that's the fundamental piece. So Dr. Stanford makes a great point. It allows her to maintain the relationship with him and to develop a level of what I would call authentic connection. Now, it's authentic in her mind. It may not be authentic in his, because he understands the artificial nature of some of the stuff that she's asking him to embrace. But at this point, you're not getting into the content domain. You're only in the process dynamic, and the process dynamic demands that you have to try to connect with folk. So in some cases, even if she over-identified with him, it might have allowed him to have a better platform because she was now so connected with him to say, I'm feeling you, but some of that stuff you're feeling, you're tripping, right? And have her trust that that was good. Why? She's not going to trust it if he's being more neutral. Why? Because she's able to say what? He doesn't understand me anyway. But if she's over-identifying at some point, it allows her to receive his message, which might have been more healthy and healing for her to hear. Eventually. Right? Than that. So just one qualifier there that says that in some cases, what we think is our worst nightmare can actually be our greatest strength, just depending on the context and how that therapeutic interaction could have played out.
I think that's an excellent point. I think, to think about it slightly simpler than you put it, if I had been more cognizant of how powerfully negative some of her transferences were to her dad, because there's that at play, but I got sucked in essentially by the presentation, the consultative bullet, which is like, this is a young African-American woman who's struggling in school. She wants an African-American therapist because she's being discriminated against. Has us all thinking a little bit too much about race, which is not that it's not important, but it took my eye off the ball of the cross-gender transferences. And so the negative transferences to me as a man, as a black man, I think I could have outweighed with the transferences to me as a black person if I had been more aware of that and addressed it the way you did. And then eventually circle back around. Yeah. So I think that's really astute. Thank you.
Do you think you would have given her just a little bit, might have kind of hooked her, if you said I too have been oppressed, maybe not disclose the details, but she probably sees you as a psychiatrist and you kind of made it in life. Would have maybe seen you as a role model, but probably because you were so control standoffish, she was like, oh, he doesn't get me.
No, I think that's exactly right. I think that's some of what Thomas is suggesting. Yeah, I think so. And to give a little bit more detail without identifying her, she was in medical school, so there was even more to that than what I had originally presented. Other thoughts or questions?
Just to ask a question.
Yeah, sure.
What were your thoughts about the countertransference and the potential pressure, the expectation that you felt sharing race and a professional aspiration with her?
About the transferences
The countertransferences.
The countertransferences.
That so that might inform also your stance, which was
Of taking a step back? Yeah. No, I mean, at the time, did I consider that? Not as deeply as I think I should have. I think in retrospect, I found myself thinking about that countertransference reaction as something in her resonating with something in me in some way that at the time I wasn't having a good time of putting together. Yeah. And I think, presenting the cases where we fall on our face, we don't help as much as we would like to, I think is important. I remember as a resident, reading a few psychotherapy textbooks and thinking like, wow, what am I doing wrong? This guy, like every patient he sees, it's like gold. Everything he says, the patient just like snaps to. And, while that book was helpful in some ways, it was also not helpful in some ways. So I think it's important to bring to light where we haven't done our best work so that we can learn from it and move forward. I think we probably have time maybe for one more case. If I do it quickly. Yeah. All right, so this is the second case. Actually, I'm going to do the third case because, not because it has a happier ending, but because there's a dream in it that I think is pretty fascinating. So this is our third case. L.N., again, it's a pseudonym, is a married 29-year-old European-American male student, also a medical student, born to two severely alcoholic-dependent parents, both parents. And they had alcoholism very badly. His childhood was marred by an extensive history of trauma, including abusive neglect by both parents from the drinking, disruption of the nuclear family unit, and episodic physical abuse by his father when he was drunk, which was very often. Multiple episodes of sexual abuse by mother's boyfriend come drinking partners, following his parents' separation. His mother had, essentially, after his parents split, his mother had a series of boyfriends, drinking buddies who ended up being temporary boyfriends who would come and stay at the house. And this patient was sexually abused by one or more of them along the way. As an adolescent, the patient found an escape from his own chaotic family in the home of a Latino schoolmate, where he was, in his own words, treated like one of their sons, fed, clothed, and welcomed anytime. This was sort of a respite for him. He initially presented with pervasive anxiety, panic attacks, and ego dystonic transvestitism. After 2 years in weekly dynamic therapy, the patient reported an uncommon sense of trust in me, and this was sort of a spontaneous thing that he shared with me one day. And he said that it had developed rapidly during our first few meetings, and he couldn't explain it. He was confounded by the fact that he was untrusting and fearful of men in general based on his childhood experiences, and he sensed that my race played an important role, but he didn't know how or why. And about a week after he reported this to me, he came back to my office for his session and reported having a dream the night before. And the dream consisted of him being at his high school and being in the basement of the high school in a tiled, sort of like a locker room shower area. And it was dark. And he saw that there was a slight glow of light coming from a doorway which led to a stairwell, but it was sort of a curved stairwell, so he couldn't really see where it was going. So he approached the stairwell and started climbing the stairs, which ended up being a spiral. And as he got part of the way up, he was confronted by a brown-skinned man. And he said he was startled at first, but somehow he felt that this person was there to help him. The person held their hand out, he took his hand, and he was escorted up the staircase. A little further, he saw a doorway open up with more light, like daylight, and at that point, this brown-skinned individual handed him a sword and ushered him up the rest of the stairway. So in the dream, he continued up the stairway with the sword. As he exited the stairway into this open field, he was confronted by what he described, I won't do it justice, but he described sort of like a very tall but fragile appearing, kind of lanky figure that was dressed in armor and was enraged, was swinging its arms around and shouting, and was quite frightening, but also appeared gaunt. He noticed that there was a small window in the armor, and as this figure approached him, he said he was terrified in the dream, but he held the sword out and actually jabbed this individual in the throat. The individual staggered, and then the patient woke up. The identity development phase that the patient was in, I would say, is disintegration. I was in an internalization phase at the time. The interactive model was a progressive model. The interracial dyad had parallel high traits. I think he had some automatic, unconscious, positive transferences to me because of my skin color. The transference initially was overcompliance, and I think it moved to a bit of ambivalence, not necessarily in a bad way, over time. The countertransferences, initially I felt a great deal of pity for him. I felt quite a bit of empathy, but also some frank pity. And then later that moved into hopefulness. And I should say, well, I think I actually talk about it a little bit later. The outcome was sustained remission of his transvestitism, which again was ego dystonic, and his panic attacks disappeared over time. He began to rethink his white identity, rethink of himself as a European American person in a way that was disconnected now from his view of his parents and their identity. And he felt that this began growing a general sense of self-esteem, and he had a growing ability to express and contain ambivalent feelings about himself and other people without splitting. I allowed the positive racial transference to buffer the patient's powerful gender-based negative transference early in treatment. I treated this patient later than the first patient I talked about, so I learned a little bit in that first case. I delayed addressing the idealized racial transferences because I realized that I could use them to bring him into treatment and have him stay rather than have him basically elope based on me being a man, which is scary, was scary in his world. And then repeatedly exploring his affective responses to white men to help the patient identify his rageful feelings, not fearful feelings and panic, but rageful feelings that were masked as panic, as he related to more personal objects, his mother, his father, and his father and his mother's boyfriends, rather than generalized abstractions like gender and racial groups. Yeah, and that's that. So that was a relatively good outcome. I'm realizing now I didn't mention in this case. This patient came to me having panic attacks. I did not treat him with any pharmaceutical agents. I treated him with therapy. He was in therapy twice a week at times. And while he didn't get immediate relief, he got lasting relief. I actually heard from this guy, I want to say now, it's about 5 years ago. So probably about 10 years after he left treatment with me. And he was doing fine. He had landed a job and he had contacted me because he was trying to get health insurance and was wondering whether he should divulge the treatment he was in with me 10 years earlier. I told him not to worry too much about that. But as that was just a brief encounter over the phone, but it sounded like he was doing quite well. Not on meds, not suffering from any of the panic, not suffering from any of the transvestitism or anything like that. So, a good outcome in this case. Any thoughts or comments? Thomas, anything?
The illustration here, I think, for me, does a couple of things. One, I think it talks about how even the lack of congruence with one's identity can look to be crystallized, in some cases, through the projections on the other people who become significant in our lives. which is what I think he starts to go through with you. The common variable, I think, there is not even what a patient understood about you being black, unless, there's a whole bunch of stuff I don't obviously see. But what he understood about the relationship between black and oppression, and the parallel between the oppression you must have suffered being black, and what he had suffered, I think, having gone through what he went through. That to me becomes the most salient issue within the context of that particular dynamic. But the most important piece is it allows you to develop a therapeutic or working alliance there that allows then some good work to be done, irrespective of whether or not the attributions he makes are correct or not. And that's why I say it's at some point it's the process dynamic that becomes more salient than even the content domain. Because even as artificial as the content might have been that he ultimately concluded, it allowed him to do the work he needed to do within the context of that, and unlike the previous case, not terminate early, which is a big problem for lots of underrepresented folk.
Right.
But that's a piece I see here. I think that was a good piece.
Something I never got a chance to explore with him was. And this would have been interesting to talk about with him, was what his experience of his friend's household was and how much they talked about oppression, if at all. And I don't know. But that may also have informed his affiliative transferences to me, if there was something there. But I never got a chance to look into that, so that's just speculation.
The dream piece is also interesting to me, even though I don't do a lot of dream interpretation and work, but it's easy, I think, to make parallels between the context of the dream, his being empowered and equipped, if you will, with the sword to go and do battle with whatever the demon is, and to assume that is gaunt and scary as the demon was, his ability to really subdue the demon. And you don't know whether or not, in some cases, that is about his fight against the oppression that he faced in his life, or thought he might face, given the identity that he was still struggling with. Or whether or not the demon that he was slaying was not the one external to himself, but internal to himself. Right? And so what he's really worrying about is, right, how do I come to grips with this sense of identity and either continue to struggle with it or finally put it to rest, by killing it off and whatever, because it wasn't really stable in the first place, which is, how the description goes. Right. So that'd be an interesting piece that I'd want to explore with this person.
Yeah, overlaid over that, the emergence from a dark place that was scary, understanding that his associations to dark and light may not be the intuitive ones that most people might have. Emerging into enlightenment, if you will, but facing this demon, this very scary thing that may be internal. I think that's a great point. Any other thoughts or comments? Yeah, Matt.
One thing I want to say is I appreciate hearing about your work.
Thanks, man.
And I enjoy hearing about your work and how you thought about the work, how you used the racial identity models in terms of conceptualizing your work with the clients. And I'm also, and based on how you describe your work, I'm guessing both folks are not folks who were able to work with at CPS. And that there's something about that makes me sad. Because it's just a part of being in a setting that can kind of promote this type of work, the type of reflection, the ability to kind of attune to your client's transference reactions and your own counter-transference reactions. And it's a process I admire, and it makes me think of like how can we support it in our work environment, which I guess can be really challenging to do, like kind of at the same time. It also made me sad to realize
Yeah, and I think, the way I was trained was to think about these psychodynamic issues, and I think I've been confronted with the concept of race my entire life, so it kind of dovetails quite nicely. So I'm always thinking about this stuff, but I think you're right. The nature of the work at UHS doesn't always make it possible to talk about it in depth, which is unfortunate, but maybe we can make some time to sit down. Aaron and I were talking about that also, that maybe we should make some time to do that more often. I mean,
the other thing I would say to that, though, is why couldn't we? I mean, we went from paper, pencil, pen records to electronic medical records almost overnight. Yeah? Why can't we make change? We find a way to make the change we have to be able to make in order to, satisfy, particular masters. It used to be that you could get a job in our mental health centers, both in student health and the counseling centers, with a certain level of credential, no more. Think about trying to be unlicensed, which is why we got all of our folk doing zillion postdoc hours, right? All the credentialing, other stuff we do. I mean, we have now input standards that did not exist for most of our places 10 years ago. Look at all the change that has been ushered in that has influenced the way in which we do our work, and you mean we couldn't change the way we actually practice clinically? Really? Now, I'm not arguing that we can just make wholesale change overnight, but if we're doing anything right, I think with the presentations we do at this conference, part of our charge, and I say this as not only the Vice Chancellor of a university, but also chair of that Vice Chancellor's Council and chair of the system-wide Student Mental Health Oversight Committee. We may not control 8 out of 10 factors in what we do, but I'll be darned if we don't control at least 2 of them. And so part of the 5% empowerment that we're looking for is let's think about changing. This is the kind of therapeutic work that allows us to have the successful therapeutic outcomes, that allows our students to be able to stay engaged, that allows them to graduate and not become casualties, that allows them to do lots of things, then who would argue against our being able to do that level of work? Now, if we don't have the time, that's not the patient's problem. That's an insufficient clinician's problem. So maybe in the models for our counseling centers, we need to have staffing ratios that look like 1 to 500 instead of 1 to 1,500. There are different problems depending on how you define it. But I want us to leave this conference feeling more empowered about what we can do with the nature of providing clinical service to the client populations we see. We are not that powerless. We aren't.
I'm glad to hear that, personally. And when you're talking about staffing, because that's the other answer to my question is, I think it really drives the lack of time that we have to go in depth with these cases. The psychiatry staff at UHS is operating at 1 to 10,000 this fall, not 1 to 500, not 1 to 1,500. So, more staffing would definitely help. And
because we don't have psychiatrists doing psychotherapy, we have them doing medication management.
If I had given this guy an SSRI and a bottle of Xanax to refill when he needed it to help with his panic attacks, we could possibly have gotten him to be symptom-free from a DSM perspective, right? We could get him to his symptoms to a subclinical level, probably with medication alone, probably. And he was already functioning pretty well. He'd made it to medical school and was doing okay in school, but he was suffering. He had a disorder of humanity, really, to use some of the terminology that Thomas was using. So I think with this case, giving him meds and saying you're good to go would have been a bit of a travesty. Relieving him of his symptoms, perhaps, but not of the actual core issue. And whether the psychiatrist is actually doing the psychosocial intervention or not, I think it's important. We're trained to do these things. I think it's important to be able to have discussions with people who are doing the psychosocial interventions so that we can all share the wisdom that we have and try to promote positive outcomes. Because this is somebody who's not coming back, right? He's not showing up at track. You know, he's at our drop-in clinic. You know, he's not coming back. He's, I don't want to say cured, but he's doing okay on his own now. He's not going to come back when he runs out of meds. Yeah, Brian.
I really like that you kind of think through it. You said that because I remember when I was a postdoc at Berkeley, I was on like the crisis on Friday afternoon, and they all wanted Xanax or like, I can't make it through the weekend without some kind of benzodiazepine. And when I would come and ask you to meet with the student, you're like, well, what are the clinical considerations and what do you really think? And I remember you really kind of slow the process down and not just give them medication, but like what's actually going to help them, you know, not just a Band-Aid. So I'd like that you do take time to like think through all these different factors. It's not just throwing medication at a student.
Yeah.
Because they want something on Friday at 4 o'clock.
Right, right, which is more of a disservice. It always happens. I think it is more of a disservice than helpful to students. Oh, yeah, Sue.
I'm just thinking about the conversation we just had about staffing, and I just feel like it's an imperative that we have the staffing to be able to do this kind of work, because I think we can put, I really appreciate all the new staffing that we're getting and we're hiring, and I think that's great, but that's to get the people in the door, and that's to have them not have wait for their intake.
Right.
What we need is to be able to see them and to do the meaningful work.
To do the work, right.
And that means more often than once a month.
Yeah.
And I think rather than we put so much energy into how are we going to get this person referred and how do we get them to accept that referral, and if we put some of that energy into actually being able to do treatment in our centers, we have the expertise. We can build the expertise that we don't have in terms of the cultural competence. And, I don't know, it just makes me think, how can we get the staffing up even more so that we can do this work?
And that's a piece I think that we have to continue to do, and certainly I'm committed to doing as chairman of this committee. I think we've done pretty well over the last couple of years advocating for the resources. So not just our regents on board and our P's on board, but now we have your student councils both for AS, UCI, and AGS on board, and even all the new registry dollars that have now come in. You know, when somebody says, this is the first time I've seen this in years, 50% of the dollars that the new registry are coming in are going to be allocated to mental health. That's pretty doggone good. When no one else, as much suffering as there is in the university, is receiving those dollars, I think that's a good thing. So we'll continue to advocate for that. But we've got to be equally adapted. I think even as a system looks to try to cope with what is the disinvestment of public higher education by the state, because this is about on us to be able to do it. But in some cases, this is not a patient, the last patient 3, that would necessarily be amenable to anything other than probably individual therapy and intervention. But there are a lot of patients we could see that might be amenable to group. So an hour of clinical intervention with, 8 patients in a group, might work. If I can do workshops on everything from managing your stress to conflict resolution to identity development to whatever, I can probably do a workshop with 20 people and keep 18 of them from ever coming in, right, on anything other than a sporadic basis. But what happens in most of our centers is that we are so backed up with client levels, backed up with intakes, backed up with trying to then get our intakes into, right, get assigned to a clinician, that the first thing to go is the amount of time we spend on all the proactive developmental stuff we used to do. So we don't do much of that. And that's where we have to start readjusting, because those are things we do control. And sometimes we just have to kind of, bite the bullet to see if we can do some of that. But, the zeitgeist, has never been better in the system for managing mental health issues right now. So if there was ever a time for all of us to feel empowered, it is now. And if all clinicians got together coming out of best practice conferences like this that we're going to try to do every year and said, we want to change the therapeutic model that we are employing, and said it would allow boys to say, we want to do X. Love the primary care suggestion that you had in the workshop this afternoon, and the imposition of that and how that helps to inform and shape what we do. There's lots of things that we could do that are within our control. Not the 80% we don't control, the 20% we do. Let's do that.
Yeah, I have a question actually, or
came out about a year ago, and it was a case out of the University of Texas on a woman named Vanessa Brewer, African-American female, who was an all-star student, like most of us like to recruit, typical of what we would take in any of our UC campuses. 3-point, high something, 8.9, 3.9 something. Goes to University of Texas and has difficulty her first semester. And it talks about how when she got there and ran into trouble, one, she didn't know how to navigate the system. Two, she wasn't clear about what to do. Three, she had never experienced anything other than academic success. So it was kind of new and foreign for her whole sense of identity about being a scholar, etc. And then when she called home for support, the only thing her mama could tell her, because she was a first-generation kid, first in her family to ever go to college, was, well, child, maybe you should come home, maybe university is not for you, which is what's typical about what happens. So at Irvine this past year, much like on lots of your campuses, 50% of the folk we just graduated at commencement are first-generation graduates, right? 48% of first-generation college students, first-generation, 50%. So this is the new norm for lots of our folk, and the good news is that a public university ought to be giving access to lots of people who aren't just the legacy kids who are kind of moving on through. It's wonderful news. But it means we have some different challenges to go. So I ran a retreat last year for my manager, my assistant vice chancellor at the time, who then hopefully drove the message down. And I used that case of Vanessa Brewer out of the University of Texas to talk about the difference between the pride factors, which we love, grades, test score, and the human factor. Because the human factors are what it is that students like that have to cope with. The things like the smarter I get, the more racially conscious, right, I get away from, and somehow can't be black if I learn to conjugate or calculate an algebraic formula. The more I connect with folk and I have varied interests, I don't have time necessarily just associated with Metro or the Asian Pacific student or the Muslim Student Union, because I'm interested in bioengineering and I'm interested in this other stuff, and there's so much time in my ethnic portrayal if I somehow have diversified interests. Those are things we don't talk about in these pride factors too. But those are the human factors that we're going to have to learn how to address within the context of that. And so as we think about those kind of cases coming in and penetrating our own boundaries of our clinical spaces, then that becomes the fuel for developing new workshops. It becomes the fuel for developing new groups. It becomes the fuel for other kinds of systemic interventions. So maybe we go and do some outreach in the residence hall, which is where a lot of our freshmen work, and we start running classes around that for a couple times a week, where we can get some of our colleagues to come and do that. We just have to be innovative in what we do, because the landscape is changing and the kind of developmental issues that our students are confronting are just different than the normal adjustment issues, and I've never been away from home, and I don't know how to share. I have conflict and the other kind of stuff that we've traditionally dealt with all these years. Things are changing. But that's very typical of what we see in first generation people. Okay?
I think that's great advice. I would also say that if you can, I would offer the opportunity to take a step back outside of yourself and look back, because even just a little snippet of presentation you make about this type of student, this type of patient, I think you actually understand and identify more than maybe you're aware. The simple fact that you recognize that this person is suffering to some degree from some kind of, some kind of analog to survivor guilt is important, and I think we can all kind of grasp onto that concept and have a sense of where it's from. The other thing I'll point you to is, I think this is pretty common across campuses, is the issue with transfer students. We have this enormous institutionalized engine that's built to help get freshmen acclimated to the university experience. And the transfer students who come in the next year get very, very little, and a lot of them end up feeling disenfranchised, not connected, right? And then they wind up at the health center, oftentimes struggling. So if you can imagine how the questions that might come up for a transfer student, do I actually belong here? How am I going to connect? How am I going to connect with these people? What do I have in common with them? Other the same questions that you're wondering about in this other population of people. And I think if you make that connection, you'll find that you actually have quite a bit more understanding, quite a bit more empathy than you may think.
I'm just not forgetting